Hello everyone, welcome to Uro-Talk channel. Today we are going to talk about one of the well-known andrological emergencies, priapism. Priapism, by definition, is a prolonged and unwanted erection in absence of sexual stimulation for more than 4 hours. The main causes of priapism are either primary, which is idiopathic, or secondary due to multiple possible reasons like intracavernosal injections like papaverine, PGE1, PDE5 drugs, hematological causes like sickle cell diseases and leukemia, trauma resulting in AV fistula formation, infective cause like malaria, rabies, and genitourinary sepsis, oncological causes like pelvis infiltrating malignancies. History. The key thing when you see a patient is to check if there was a sexual stimulant. Time of onset. Is it painful or not? If there is any history of previous episodes. If there is past medical history of trauma, malignancy, or hematological diseases. And to check patients' drug history, like erectile dysfunction medications. On examination. When you examine this patient, USA a systematic A to E approach. Provide them with analgesia if significant pain is reported. Examine their abdomen to look for any palpable abdominal or pelvis mazes and organomegaly looking for malignancy. When you are examining the patient, you are also looking for if there is a rigid tender corpora with soft glands, which could indicate ischemic priapism. And also perform a DRE to look for signs of any advanced malignancy. Baseline investigations. The baseline investigations for this patient should be baseline bloods, includes FBC, white cell count, platelet count and coagulation profile, looking for signs of infection or hematological malignancies. Then aspirate blood from corpora, using large butterfly needle. This is important because it will help you to determine whether or not this is ischemic, non-ischemic or stuttering priapism. Classification. Ischemic, low-flow priapism which is usually associated with disorder of the venous outflow. Non-ischemic, high-flow priapism which is usually associated with disorder of the arterial flow. Stuttering recurrent priapism. Blood sampling from corpora. For ischemic priapism you will see that the blood gas will reveal an acidotic results with high PCO2, while non-ischemic priapism will have similar results on the arterial blood gas. Ischemic priapism should be treating the same as compartmental syndrome, and the key histological changes include interstitial edema, progressive destruction of sinusoidal epithelium, exposure of basement membrane after 24 hours, and then smooth muscle necrosis with fibrosis after 48 hours. 95% of priapism cases are ischemic. And this is due to venous occlusion. Causes are multiple includes intercavernosal injections, drugs includes erectile dysfunction medications, cocaine, heparin withdrawal, trazodone, phenothiazines, sickle cell disease and metastatic diseases. The intracavernosal pressure is more than 80 mmHg. Erection is painful and rigid, with low or abscissant cavernosal flow. Blood gases will shows hypoxia, acidosis and dark in color on aspiration. Non-ischemic priapism. It is due to unregulated arterial flow. Usually it is painless and less rigid. Causes includes trauma, saddle injury to perineum and subsequent fistula formation. Aspiration will be similar to ABG results. And it is self-limiting. Stuttering priapism is usually seen in sickle cell disease. Commonly non-ischemic, but can be also ischemic. Penile Doppler ultrasound. Not required to distinguish between ischemic and non-ischemic priapism. In ischemic it will show little or no flow in corpora and cavernosal arteries, while in non-ischemic it will show high peak systolic velocities indicating fistula. Management of ischemic priapism. It is a medical emergency, which might require urgent intervention. The aim is to restore penile flaccidity to prevent damage to corpora. There is a window between 4 to 72 hours, and after that surgical intervention will be deemed to be futile. There is 3 forms of management to the ischemic priapism. Includes aspiration of corpora, intracavernosal phenylephrine, and surgical intervention. Aspiration of corpora. You perform penile block with 10 mL of 1% lidocaine. Large gauge butterfly into corpora. Can insert one on either side to allow for irrigation and drainage. Then aspirate stagnant blood. Continue until fresh red blood and detumas is achieved. But you should only aspirate 100 to 150 milliliters. But the success rate is only around 30% of the cases. The next step will be injection of intracavernosal phenylephrine. Keep butterfly in situ. Phenylephrine, a selective alpha-1 adrenergic receptor agonist. And it must be given in monitored settings as it can give some cardiovascular side effects. Dilute phenylephrine to 500 micrograms per ml, 10 mg in 20 ml saline, and give 0.5 milliliters every 5 minutes. Maximum dose is 1 mg in an hour. For priapism caused by intracavernosal injections, terbutaline can be given. Surgical interventions. The key thing is penile shunts. Aim of this is to provide an exit of ischemic blood from corpora to restore normal circulation. You do try distal shunts before proceeding to proximal shunts. Distal shunt. This includes the Winter shunts, Ebhage technique, T-shunt and Algorab procedure. The Winter shunts involves the insertion of true-cut biopsy needles through the glands into the corpora multiple times to remove small cone segments. The Ebhage technique involves use of the blade to insert through the glands multiple times through the corpora. T-shunt involves inserting the blade through the glands into the corpora and turn it 90 degrees then withdraw. Algorab procedure involves the removal of cone segment of corpora bilaterally, then subsequent closure with absorbable sutures. Proximal shunts. First technique is Quackel shunt. Open proximal, corporospongiosal, shunts. Through transscrotal or perineal approach, to create communication between corpora cavernosum and spongiosum. Possible complications includes unwanted urethral cavernosal fistula, urethral strictures or development of cavernocytes. The second proximal shunt technique includes Greyhack's procedure, which involves mobilizing the saphenous vein below the junction of the femoral vein and anastomosis the vein, end to side, onto corpus cavernosum. Venous shunts may be complicated by saphenofemoral thrombus formation and pulmonary embollism. Penile prothesis insertion. Prolonged ischemic priapism will lead to necrosis, fibrosis with penile induration and or shorting, which likely to lead to erectile dysfunction. Indications are prolonged ischemic priapism more than 36 hours, smooth muscle biopsy proven necrosis, failure of all treatments and MRI evidence of fibrosis. Prothesis comes in different types, either soft, malleable, inflatable implants. Insertion of penile prothesis early lead to better outcomes, mainly due to development of fibrosis. Management of non-ischemic priapism. Likely due to trauma, laceration of cavernosal artery lead to unregulated flow and erection. Aspiration is not urgent, however patient need to be transferred for assessment for embolization. Penile Doppler might show fistula, selective EV arteriography might locate site of arterial injury. Can be managed conservatively, however embolization is recommended and surgical ligation is rare. For sickle cell disease, main management is oxygenation, rehydration and liaison with hematologist. Thank you for watching. For more Uro-Talks topics, please subscribe to the channel.